And again, I'd like to also thank the media, both in the room and on the phone, for being patient today because of the scheduling advance for us and being efficient at our board meeting today. I'm joined with Mr. Dick Carter, the board chair of the Saskatchewan Health Authority. Today marks an important milestone for healthcare in Saskatchewan. Today, the 12 regional health authorities officially joined together to start our shared journey towards a redefinement of Saskatchewan healthcare in our province. As a single provincial health authority, the opportunity now exists to act as one system in a way that has never been possible. I want to emphasize that today is truly the beginning. It is truly day one, and we've just started this multi-year journey towards transforming the Saskatchewan healthcare system. All the work that's been done to date is really accumulating in making sure that the organization was as prepared as possible for day one, ensuring that we would be able to not just legally operate, but also to ensure that transition was as smooth as possible to ensure the safety and quality of our patients and the staff that take care of them. We will continue to engage patients, families, stakeholders, First Nations, Métis people, and other healthcare partners as we start to work towards redesigning our system over the next few years. As I said before, there's a difference between transition and transformation, and the transformation work is about to begin. So thank you, and we'd be happy to answer any questions.
I guess just first off, I mean, someone who walks into a hospital yesterday versus walks into a hospital this afternoon, I mean, are they going to notice anything substantially different in the kind of care they're receiving?
The simple answer is no, other than perhaps a phone greeting where somebody answers the phone with the Saskatchewan Health Authority tag. It was intentional to ensure that day one of operations from a patient and family perspective was going to look a lot like day -1. So those same people that worked in the system that are taking care of patients, those familiar faces will be the same that are in the system today and moving forward. We were very intentional about that and ensuring that the transition was as smooth as possible.
Are there any other aspects of the transition that are still ongoing? For example, are there more vacancies that need to be filled in the new health authority?
Certainly, you know, we've just actually started phase 1 of the recruitment for the Saskatchewan Health Authority, and I'm happy to say we're 95% complete on the senior leadership team. The next phase will be recruiting that next level of leadership across the SHA, and that's going to take some time over the next few months. We'll be filling those positions, and then we'll moving down to the director level. So it's going to be a period of months before we actually have the Saskatchewan Health Authority out-of-scope management team in place.
So for people who don't understand what phase 1 is, phase 2, what are these types of jobs?
Okay, so the first phase was the most senior jobs within the organization, those VPs and physicians executives, and we've been sharing that information both publicly and with staff across the health sector. That next level, and those jobs are primarily located in Saskatoon and Regina. There'll be some folks in PA and outside. The next level of the organization are those more senior leaders that will be responsible for things like facility management and nutrition and pharmacy and other areas. Those roles will be executive roles, executive director, and they'll be distributed across the province. They will have provincial responsibilities, but we'll be locating them closer to home. Really being true to that provincial oversight with local presence and local management for the healthcare system, and to be able to liaise with both the staff, patients, and the communities.
So how does this differ then from having the different 12 health regions?
Well, I think at the starting point, the biggest difference is it's under a single governance model, so there's no longer 12 board of directors and 12 leadership teams. There's been a significant reduction in the most senior level opportunities or roles within the organization. As you've probably seen from some of the releases, there's been about an 86% reduction in the number of vice president or CEO roles, as well as going from 12 board of directors to a single. So the single biggest change will be to finally be able to have the system operating under a single strategic direction and a single authority. And as I said before, not a lot of change on day one. That's been intentional for to ensure safety and the quality of care of our patients. But as we continue to build and evolve, you'll start seeing things where you see more provincial focus and provincial policies and programs being put together. So you're seeing a lot more similarities across the province, but also programs that are responsive to community needs.
You're
So
talking about
patients don't know.
similarities around the province, but how is it gonna be possible that one doctor gonna decide at one place that MRI could be necessary, but one other doctor on other place can decide that it's not necessary? So that patient all around the province could have the same service everywhere. How can it gonna be possible with one health authority?
Well, I think the easiest answer to that question is it's not gonna be easy, but the health authority is not going to have to create those standards for what actually meets the need for a diagnostic test or a laboratory result or a way in which care that is tailored towards patients' needs is also built based on evidence and medical evidence, and what we're trying to do is take that evidence across medical care and instill provincial standards that create mechanisms for patients to access care in the same way across the province. And that has been something that through the advisory panel report was mentioned. That's in some ways the 12 regional health authorities with geographic boundaries and different policies that guide what goes on within those regions sometimes provide a barrier for patients to receive the same type of care or access across the province. And really the ultimate goal for the new Saskatchewan Health Authority will be to create those standards. And when I say standards, I don't mean it in a bad sense of the word. I mean a gold standard, so that patients are receiving the very best care and access to that care in a similar way across the province, regardless of where they live.
How long do you think it's gonna take?
Well, I think it's gonna take multiple years to get through. If we look from our experiences in other jurisdictions like Alberta or Nova Scotia, where they've already moved to a single health authority, they're not done their work. I think you have to be very deliberate and methodical in how we approach this, and we will. Once we bring these teams together, we'll be prioritizing areas. Diagnostics, since you bring up diagnostic imaging and lab, we think there's some significant opportunities provincially to bring some provincial guidelines and standards towards the use of those services, and those will be addressed likely first, but it will still take months to years to actually have it implemented.
Obviously with the shuffle, you said 86% reduction in terms of like upper management
Yep.
and CEOs. How much severance have you had to pay out, and how long will it take to recoup those costs and actually start to see some savings?
So I think, there was a news release today around the amount of severance that's been paid out today, particularly related to the CEOs in the system, which are really the people that were first impacted through this change, and is $4.1 million. That number will change as more people get opportunities to apply for roles within the organization, but for those folks that are currently in roles that don't land a position, there may be severance down the road. We expect that the cost of severance of other folks within the system is going to take a few months, maybe a little longer, depending upon how long it takes to fill the roles within the organization, because we're giving folks an opportunity from across the sector to apply for those roles, and we'll be filling them over the next 3 months. So we don't know what the ultimate severance number is going to be, but it will evolve as we start filling positions, and people choose to exit the system because there's not meaningful work for them. With respect to how are we going to offset, I think one of the offsets is the fact that you reduce your costs automatically with the number of CEO roles within the sector, because you're not spending money on 12 CEOs, and you're not spending money on 12 boards of directors initially, so there'll be some offsets. But that's not to say that they would be fully offset. We won't know until ultimately it's done.
Sorry, so would 4.1 million be the maximum severance pay if no one who's getting severance pay gets another job with the authority? Or can that number be higher?
Sorry,
Would 4.1 million be the maximum that would be
no,
paid out in severance?
it's not. It's the 4.1 million that's been released already was related to the people that have already been severed, the CEOs, so that the number will be higher. So anybody who's severed after the fact, those costs have not been incorporated into that number.
And talking about cost, is it possible that over the years some hospital could be closed in the province to save money?
Well, the SHA would be making those decisions directly, but how services eventually roll out in province-wide would be something that would happen with consultation. Whether or not long-term a hospital would close, couldn't say. I'm not sure. We know from past reviews of the healthcare system, there are small volume facilities across the province that are challenged to recruit and retain staff and meet the definition of a hospital, but there are no short-term plans to be closing those facilities. But ultimately, once the new Saskatchewan Health Authority creates a strategic plan and has approval for that plan and direction from government with respect to what the opportunities are to integrate health services across the province, that will include what we do with existing facilities. And but we just don't, you know, there's no preconceived notion of that today.
There's a lot of concern about local voices being heard in this health system, and you referenced Alberta earlier, and when they shifted to one health authority, they ended up restoring zones in terms of geographical, because places like Fort McMurray felt like they had lost their voice. How do you ensure that you don't have to kind of scale back and go back to those zones?
So there's going to be a number of different ways, and again, it's a great question, and one of the things I'd say is we've learned from our partners in Alberta and Nova Scotia, which both have some form of geography or zones around how they're distributing services. One of the things that was important in the advisory panel report is that we don't simply recreate regional health authorities, because then we would defeat the purpose from dealing with those challenges of those barriers that are believed to cause challenges for patients in accessing care with regional health authorities. So we have designed 6 different areas across the province to help distribute both administrative and clinical staff. They're not regional health authorities. They don't have independent decision-making ability or budgets, but there'll be ways in which we will be able to have both administrative staff, as I said before, that we're going to ensure that there's leadership, management, and other executive leaders distributed throughout the province so that they can stay connected with communities, and these areas will help us do that. The other thing that we'll be doing very shortly is, as we continue to broaden the engagement around how we transform the system, is the creation of community advisory networks and other ways in which we'll actually engage with communities across the province and other stakeholders to help redesign the system. That work hasn't been completed, it's just about to begin. So it's going to be one of the ways in which we're going to ensure that services are designed in which meet the needs of the community. In the short term, what we've done to ensure we haven't lost touch with those communities is we've rolled in, excluding the most executive components of leadership of RHAs on day one, those other senior leaders across the province will be rolled into the organization. So one, they have an opportunity to apply for new jobs, but also to ensure that those same faces that the communities are used to interacting with across the province are still within the organization to smooth the transition.
This question might have been asked here before, but I'm also wondering with the previous issues that we've had with doctors here, doctor shortage, especially down here in Estevan at our hospital. Is there going to be a way that this new health authority is going to step in and increase the recruitment here in the southeast and even all of the province here?
Hi there, yeah, if you could please identify yourself before you ask your question, that would really help us here in Saskatoon. Who are we speaking with?
Sorry, yes, that's my bad. This is Matt Cinnamon, Discover Estevan.
Okay, great. Do you want to ask, or you're okay to answer, or would you like
Sure.
me to ask it again?
No, sure.
Okay.
So another great question. As everyone knows, the system, you know, over the last few years, we've had some significant improvements in the recruitment of both specialists and family physicians across the province through collaborative work of the 12 regional health authorities, local communities, and an organization called the Physician Recruitment Association of Saskatchewan. We hope to continue that good work of recruitment and ensuring retention. I think one of the big advantages that moving to the single health authority with respect to the recruitment, as well as coverage of physicians across the province, is we're now dealing with a provincial pool. Although physicians, like other healthcare providers, will be distributed throughout communities as they are today, we'll also have the ability to actually draw on a provincial pool of locum resources, and then hopefully covering shifts where in history it was problematic for regions to do that, and it was a challenge with recruitment and retention. Our focus hasn't stopped as a province on recruiting physicians throughout, both in the southeast but also in the north, where we also have challenges. And part of that is also working with the Physician Recruitment Agency, which will continue their work as the SHA forms.
Sorry, I still have another question. You talked about an 86% reduction in like CEOs and senior administrative staff. but then there's talk about hiring new executives and executive directors. Is there a percentage associated with the new hires?
So, and I just want to be clear, so that 86% is the reduction in CEO and VP roles from the 12 RHAs to our new system. Even in the new 12 RHAs, there are executives below CEO and VP, and it's really that level that I'm talking about is the next level of hire for the SHA. So those roles are not necessarily, a number of them aren't new. It's the scope of the roles will change, and we're going to be recruiting new folks into those roles. With respect to the overall reduction of roles, when you combine them, we haven't completed that work yet. That's why we haven't started the recruitment at that next level. But we will be sharing that information publicly as we start looking at what types of roles are required for the next level of the organization. But there's not a simple duplication where we're swapping executive roles as we recruit.
Bringing in that many new people, are you worried about the learning curve of taking out all that expertise that was already there in those health authorities and bringing in brand new staff?
No, I'm not worried about it. I will acknowledge, because certainly I think it's a fact that with the creation of the new organization, whether you're having existing CEOs take on roles or existing VPs or somebody new, they are new roles and they are big roles. You know, like they are significant differences, and those things that made people successful in their old roles might not necessarily do that when you're in an organization this size and scope. But I think one of the things that we've done by focusing our recruitment efforts on people inside the province, because we've done that for most of the roles underneath mine. I know my job was recruited both inside and out. But by keeping our expertise inside the province, it will help smooth that transition. You know, if the senior leadership team could be used as an example, there isn't a single person on that team that isn't from the Saskatchewan healthcare system in some way, shape, or form in their history, but also the experience that we bring to the table with those folks will certainly be an advantage as we move forward, but that doesn't say that we're not going to have some growing pains, but I'm confident that we're going to do our best to smooth that by keeping the people in the system that know how the system works.
And so maybe just one more question about what the patients will expect. I mean, is there still going to be enough local people here that you're not going to have to be phoning? If you're in Regina, you're not going to have to be phoning someone in Saskatoon to get, you know, even like, so a media person, right? I mean, that's all going to change? Like, I'm just thinking about specific kind of things that will change. Will you have to phone some nebulous
so again,
bureaucracy?
So again, it's a great question, and we've been very conscious about it. So again, one of the things from a patient perspective, nothing changes on day one. So the phone numbers that a patient phoned yesterday to access care across the healthcare system have remained the same. The websites, although we have a new Saskatchewan Health Authority websites, all the existing websites where many patients go to access information, particularly around immunization and public health and other services, those are still intact, and that was intentional. And we'll be very careful and thoughtful in how we move that forward and communicate across the province when we are making changes where we see them being an impact on patient. But today, you know, a patient who's seen a specialist and been put on a surgical waiting list or is booked for surgery, that doesn't change. And the information that they've been provided to access that service as they get closer to the date of their surgery, that is still something that's intact.
So when you say several years, I know you have a number
Yep.
in your head. What is it, 5 years, 10 years?
I have a number in my head, but here's the answer to that question. Alberta Health Services was the first one. They created they've been at it for 8 years. I don't know if they would say they're completely done yet. I think one of the advantages we have though as a province is we've been able to learn from some of the challenges faced by other jurisdictions that have done this, particularly Nova Scotia and Alberta. So, and we're just not as big as Alberta, but it's still a complex system. So how far we get with respect to, and when we say we're done, I don't think we're ever going to say we're done. I think there's going to always be opportunity, but I think in my head, I think it's going to take a minimum of 3 years to rebuild the infrastructure to support the single health authority. And at that time, there's going to be some things that won't be addressed because we're building a new infrastructure and ensuring that patients don't experience adversity in accessing the health care system. But I also think there's some things that we would want to do as a province in that fourth and fifth year that we're just not going to get to until we actually build that infrastructure. And some of the things like that is You know, we've been very conscious about including physician leadership in the new organizational structure, because we know every high-performing healthcare system in the world has physicians in leadership roles. That's new to our province, and it's going to take us some time to ensure that we support that work. But part of that is how do we better collaborate and incorporate healthcare services outside of a family physician's office with physicians, because it's a big gap for patients with respect to accessing specialist care and other services, and I think that's going to be a longer-term challenge for the systems. It has been in Alberta and in Nova Scotia, so I think minimum 5 years. But you know, I wouldn't say your guess is as good as mine, but that's where I'm landed today.
So you say, you know, day one, things aren't gonna change, but let's fast forward to 3 years when you do say things are gonna change. What does that mean for Joe Schmo who's trying to access healthcare? What is the healthcare gonna look like in 3 years then?
So that aspirational vision of what 3 years would look like is that a patient would experience a much more seamless access to services across the province. And if we look at some of the challenges we've had in the past, where patients have received either mixed messages or, you know, simple things like having to repeat a family history or a medical history each and every time they interact with the system. You know, in a fully integrated system, you know, 3 years out, we should be able to ensure that a patient doesn't have that challenge or access. We should also be able to, in a provincial organization where we have challenges regionally, where that be in the southeast, southwest, or some of the challenges, those significant challenges in the far north, to be able to draw on the resources across a $3.8 billion organization instead of just asking your partner organizations if they can help out would be a significant improvement. So to be able to respond to communities in crisis, but also to be able to plan proper so that communities never get in crisis, I think there'll be a significant improvement by having a single provincial health authority.
We're going to move now to any outstanding questions that are on the call. If you could please just identify yourself and then ask your question.
Michael Joel Hansen here with the Moose Jaw Times Herald. My question is, how much authority will local leadership have? Like, what will they be able to make decisions? What decisions will they be able to make in-house, and what will have to be run up the pole to Saskatoon?
So, great question. I think this is going to be one of the key infrastructure and administrative issues that will be addressed as the organization evolves, is getting the decision-making as close to the patient care level as possible, but also ensuring that we are true to the vision of a provincial system so that we're seeing provincial direction. So to simply answer your question, we haven't landed exactly where that decision-making threshold will be, but we do know that we want it as close to patient care as it can be. We want it to be responsible for the needs of that community, and it won't be a cookie-cutter approach, because each and every community is not the same in the province. But at the same time, we want to address those areas where we don't have provincial standards and we don't have alignment. So there will be a significant amount of local area decision-making, particularly around how it supports primary healthcare networks and what services are required given the community needs. But there will be a significant amount of direction provided at the provincial level, because that's also part of the intent of creating the new authority.
Hello there, Kenneth Brown, West Central Crossroads, Kindersley, Saskatchewan. I guess my question would be more for the board chairperson, Dick Carter. It's no secret that rural facilities across the province are struggling with their capital needs. Or at least that's what I've heard at board meetings and through other events. And I was just curious, with the board, with regional board, I mean, they were always being pulled in different directions, of course, from the communities and the needs of local facilities within the health regions. With there being one single authority and board, it's safe to say they will be pulled in more directions. And I was just wondering if there was kind of a system internally set up so that they can kind of sift through the needs, the capital needs of all facilities really, to determine where best to spend money.
Well, I'm not sure that's best for the chair, but I'll give it a quick answer and then maybe pass it over to our CEO. As a board, we are very aware of the need for the board to make sure that there is communication channels from all parts of the province, and that this does not become a Saskatoon or Regina-centered organization. So we are working with management on that. That would include, you know, how the infrastructure needs are addressed province-wide. And maybe with that, Scott, if you want to add anything to that, I'll pass it over to you.
Well, I think, again, one of the, and I think you brought it up yourself, is the push and pull that happens with multiple regional health authorities and with multiple facility pressures across the province, and again, 12 different prioritization lists. One of the things that the new authority will be able to do is to actually pull that together for the board's consideration, as well as discussions around funding and budget and all those things that have to happen operationally when it comes to the state of the nation with respect to our facilities and our capital. And that hasn't happened you know, in the sector for a long time. So even to provide clarity with respect to where things exist on priorities and what opportunities there will be and how those align with the strategic direction of the SHA will be something I think will be a vast improvement down the road. But it is not something that has been prepared to date, and it will be part of the work in progress as we start working on what the new system looks like and what our needs are, both from a facility and capital perspective.
Thank you.
Okay, all right, thanks everybody for coming, and thanks everyone for dialing in.
Thank you very much.
Thank you.